Hi there. I'd like to thank the organizers for inviting me. I'm very humbled to be presenting in this forum. I'm an adult epileptologist. I have not yet made substantive contributions to the literature on LGS, but I think I have a background and a set of interests that I think gives me some observations that hopefully will be useful towards this question of defining LGS in undiagnosed adults and how do we find them. A little background about me. As I mentioned, I'm an adult epileptologist. I trained at MGH for clinical epilepsy fellowship and did work with Ann Paduri in zebrafish models of genetic epilepsy. And I'm supported by various grants for the generation of zebrafish and mouse models of some rare epilepsy syndromes like SLC6A1 and CDKL5, which have been linked with LGS. And I've also served as the site PI for the epilepsy learning healthcare system for 2 years when I was at MGH, but I've recently started a lab at Northwestern, and so that's where I am now. So without further ado, why identify undiagnosed adults with LGS? This is a room that probably doesn't need much convincing as to the merits of that, but one of the reasons would be to be able to more comprehensively understand how LGS evolves over the life of our patients by completing natural history studies, being able to recruit these patients for clinical trials to be able to offer them novel therapies that will hopefully also improve the management of all of our patients with LGS, to be able to perform comparative effectiveness research. In other words, being able to make better use of existing treatments that might not, instead of waiting 10 years for the newest treatment, maybe we can do more with the ones that we already have, and that would be one of the goals of being able to have access to these patients, and of course, ultimately, being able to improve the care and outcomes of patients with LGS, as well as quality of life for the caregivers too. So ultimately, this all adds up to a goal of trying to maximize the number of identified patients with a confirmed or probable diagnosis of LGS across the lifespan, but for the purposes of this talk specifically in the adult population. So what's the status quo? What are we doing wrong? What are the challenges in adult LGS management and diagnosis? This is a topic that has been discussed extensively today. I don't need to go into too much depth except to say there's many different reasons why we might not know amongst our adult patients who has LGS. There's been limited transition, or let's just say that there's room for improvement with our programs related to transition from the pediatric to the adult epilepsy care. So these patients, maybe they never transition, and so they're just not seen by adult providers. They might be lost to follow-up. I certainly have had a patient who's been spending the last 20 years in a group home on the same regimen, prescribed through a community neurologist, and so these patients, there might be some misconceptions about whether this is a condition that's fully static or that has any new therapies to be offered, and so these patients may just not be making their way to the right centers that are devoted to doing guideline-based and evidence-based care. Another one is that the features of LGS can be variable in adults, and I think adult providers would benefit from additional education about the differences in the appearances of LGS across the lifespan and how, specifically the EEG phenomena can change. We may not see as much evidence of the slow spike wave and the generalized paroxysmal fast activity. The appearance of seizures may also change as well. And in addition, amongst epilepsy providers on the adult side, there can be a lack of awareness. There may be a lack of interest. Some of this is driven by a lack of resources on the adult side that might be required for the care of these complex patients. And then lastly, the guidelines that have been published might have limited visibility to adult providers, and it's fair to say probably have had some limited uptake. And so, how do we address this? So, so when I was given the topic of this talk, finding undiagnosed cases of LGS in the adults and how to find them, there are a number of other related questions that immediately sprung to mind. So not just how to find them, but like, how do we stop losing them? Or how do we have them find us? lots of questions that deserve to be answered, and there's probably no one single thing that we can do that would improve this. And having some background in QI, I would think of this, the solutions need to have more of a systems approach. And so this is just one, this is one vision. This is more of like a perspective talk based on my experience as an adult provider, things that could be implemented and linked in certain ways that might allow us to increase the number of patients that are starting from the pediatric side and ending up with us on the adult side. And so this is sort of, compared to the first slide, if this is sort of like a game board, there's a lot more pieces on the board now, pieces that hopefully will help this process to take place. And it would all start with the identifying or the defining of what I would call clinical champions in adult epilepsy for adult LGS patients. And in the QI world, at least with Epilepsy Learning Healthcare System and my role in it, it was critical for systems of change and changing practice or patterns of practice patterns in the clinical setting across many different sites to identify champions, people at that site who will be visible, who will be a visible beacon for the cause, and that can attract other people and to help educate people locally. This person's pictured with a sword because they're the ones they're gonna fight some battles on behalf of patients with LGS. Hopefully they'll coordinate some care, lead local education and research efforts. We could argue about what the best selection criteria would be. For one, definitely they have to have some expertise in epilepsy, some interest in DEE and LGS in adult patients, and arguably they should probably already be a part of a health system or have line of sight to a health system that has access to some LGS relevant clinical services that would include social work, non-pharmacological treatments like ketogenic diet. This can be pretty rare, I would think, in my experience amongst adult epilepsy clinics. We have it at Northwestern, but we didn't have it at MGH. And also access to epilepsy surgery and clinical trials. Number two, as a piece of this, would be defining centers of excellence that are linked to adult LGS. So this concept of centers of excellence has come up in many different circles, including with the LGS Foundation. I'm not fully apprised of what current efforts might be in this space specific to LGS, but I would argue that it's likely centers of excellence will be defined around pediatric neurology groups where the most number of new LGS cases are being diagnosed, but that we should link these to at least one adult epilepsy clinical champion. And this is an idea that's really borrowed from thoughts that Dr. Schechner shared yesterday with the CF National Patient Registry. He was telling us that at a certain phase, their involvement in the registry required sites to identify and partner with specific adult providers for the purpose of transitioning. So if it's a priority for us to have a pipeline that would increase the number of adult patients with LGS that are being seen by adult providers, I think it sort of starts here. And number three would be to use the LGS Foundation's LGS registry to engage with patients for all the things that it's doing now, but in this context with a special emphasis on maintaining contact in a longitudinal way. So helping to support the discussions that would be taking place with providers, setting the stage for discussions about transitions of care, but also helping to share information about these clinical champions of adult LGS care that maybe they're not present or they're not available at that very specific site, but this would be a clearinghouse for information about trying to identify these people. And the goal here would be to retain patients in care systems where they're having access to the best, guidelines-driven care and access to the newest research and trials. And of course, number four is training for transition. I don't have a lot of unique observations about this element, except to say that we all acknowledge that this is a very important component of this process that would allow, a seamless transition from the pediatric to the adult side, and something that should be optimized in this setting too. And then number 5, hopefully with the identification of these clinical champions in adult epilepsy, we'll be growing a greener pasture for our pediatric patients to enter. I know there's a lot of trepidation in going to the adult side. It is very different. Some of those aspects are not going to change overnight. Some of them may never change. But hopefully, one of the elements that can be improved through a systems approach like this would be for this clinical champion to now have a role as like a learning catalyst to help the other providers in their centers to be up to date on the current thoughts regarding the diagnosis of LGS in adults and the current management. As has been discussed in this forum, there's a number of publications that have been published out there to help with this, the number of different topics that could be included related to ASM management, identifying these patients, genetic testing as well. And the goal here would be to increase the provider's confidence beyond just the champion for identifying and managing LGS. And number 6, this might have been the topic that's probably the most directly in the crosshairs of the talk's title, but I thought that for these tools to be valuable, they sort of need to be in the context of a system that can benefit from capturing the patients that might be identified from them. But this is the piece related to developing, validating diagnostic tools for undiagnosed LGS in adults. There have been some tools that have been published, for example, by Pina Garza, the REST LGS score. And this is essentially a scoring criteria comprised of 4 major, 4 minor criteria that can be assessed by clinicians. And the goal would be that this criteria could apply to patients who may be already in the healthcare system under our noses, but for various reasons, maybe they don't have sufficient medical records. We don't recognize them as classically fitting the description of LGS, but could fit the criteria for probable LGS under scoring criteria such as these. And this study looked at 200 patients across 2 sites in a retrospective fashion, but did show evidence that most LGS patients, when evaluated in a blinded fashion, had a higher score on this criteria than patients who are just run-of-the-mill drug-resistant epilepsy. And so in a related way, computable phenotypes, I'm not going to talk much about this except to say we have manual scores that can be done by providers, but we can also train a computer to do those sort of things, maybe using the same sort of criteria as REST, LGS, or other ones that could be developed, and maybe automate some of that with natural language processing and LLMs. And the gap here would be in validating them across sites, but also prospectively, making sure that they are actually useful metrics that seem to hold up. And of course, if they're validated, we would then need to improve their visibility to adult providers because they won't be useful unless people actually know about them and know to use them, which might include integrating them into clinical workflows. And lastly, this funnel is sort of all going towards this last piece, which is about, I say, adult LGS surgery and clinical trials. This is really sort of what Dr. Ralston was talking about, all the options that maybe already exist and the newer ones that are on the cusp. Having adult LGS patients be included in this conversation within adult neurology and adult epilepsy will allow them to have access to all of these options that they otherwise might not. And this is a piece that I think would definitely benefit from the involvement of a clinical champion in epilepsy because different epilepsy surgery programs definitely have cultures. They have ways of thinking about patients. They have patients who they may sort of just straight up exclude from being eligible based on just practice patterns and historical practices. And so it's good to have somebody maybe on the inside who can help to be a catalyst for learning, to share some of the newest understanding. It definitely was eye-opening to me to see in doing the reading for this that, at least based on meta-analysis, there's evidence to suggest LGS in all its heterogeneity, when there's a focal cause, can actually benefit from some resective surgeries with good seizure reduction. So that's a point that I think could be benefited through this sort of process. And then the goal here would be to be able to expand the access to surgical interventions and clinical trials for LGS patients. Yeah, so an overview, this is all sort of, no one of these pieces alone might do the job, but I think function together through a system that spans from the pediatric to the adult and is based on these clinical champions, probably using a QI infrastructure and supported in large part by the LGS Foundation, could move the needle on this and answer the question to identifying and retaining adult patients with LGS. And with that, I'd just like to leave you this, this image and this quote that's often sort of running around my head, and that's Hannibal crossing the Alps with his train of elephants to go attack Rome, and the quote that's attributed to him as, "I shall either find a way or I shall make one." And I think I feel that way a lot about different things. You know, sometimes tasks seem impossible, but if there's a will, there's a way, and it starts with us. So thank you.
I have a comment. I do have a comment. So as parents, how can we band together to find that champion in our level 4 epilepsy center?
Right. Well, so this was, I was presenting this sort of as like a vision, like as a perspective. Ideally, there could be some formal program that might support this. I think in the short term, people who would consider themselves to be clinical champions for adult LGS patients would be able to make themselves known to you. There's probably some in this room. I would consider myself one. Zoe is one. In the long run, I think, yeah, it would be great if the LGS Foundation could help to cultivate those individuals and then share that information.
I'm a parent, but I'm also a hospital chaplain. And I just want to offer hospital chaplains as a clinical champion, as a possibility for that. And also just in a number of our presentations in terms of care teams. Again, as a hospital chaplain, I do a lot of advocacy. And as a parent of an 18-year-old with LGS, I have a lot of information. And so, for example, I'm often meeting families. When I review the chart, I see LGS, and the parents are not aware, right? And so, and you know, I have good clinical skills. I'm going to follow their lead, but when the opportunity comes up, you know, I can say, you know, what have you heard from the team? What's your understanding? What are the diagnoses? What are the labels? Have you ever heard of LGS, right, or Lennox-Gastaut syndrome? And there's a foundation that can be so helpful, right? And I actually had a family recently who lost their child, and LGS was in the record, and the parents got angry every time a caregiver came in the room and mentioned LGS because they had no idea what they were talking about. And it was painful to me of like, you know, what a lost opportunity in terms of being able to access these resources.
Absolutely. That's a great point. You know, as a physician, I was sort of very myopic towards the idea of these clinical champions being physicians, but you're right. I think there's people at all levels that are working in this healthcare space that have contact with patients who patients would benefit from being able to learn from. So yeah, you're absolutely right. It's a great idea.
I think this is great. I'd like to comment, though, that my challenge has been as a parent, but also I have another job where I do mentoring for families in Pennsylvania. And I have had a handful of families that have ended up identifying their loved one as having LGS. And they're mostly older families. And they've said, you know, when I've mentioned about the foundation or finding a new epileptologist, the answer has been, no, the doctor told us years ago, there's nothing that can be done. We can't change the medication. There's no life expectancy. There's no sense in doing anything. So I think there was a lot of damage done at some point in time for a lot of these families. So I think we have a lot of work ahead of us. I don't abandon these families. I check in on a regular basis and hope that at some point my persistence becomes a positive step forward for them. But I don't think it's going to be an easy road. But I hope the younger families, a lot of them, you can reach, because I think that's where the future lies.
Thank you for that. And again, I think you're echoing again my own oversight in not sort of capturing the fact that, yeah, there's many people who interact with patients who would be able to supply information. And as a part of this systemic approach, it would be good for there to be an outreach component that might specifically go after patients who are in their older years, who exactly like you said, they've been told based on old information that was maybe never correct, but back in the day when there were fewer therapies, maybe seemed more appropriate to try to undo some of that.
We have one more over here.
Sure.
Hi, I'm also an adult epileptologist, so solidarity. And I do just, on the topic of how to champion an adult person, I do echo the importance of organizations like AES, LGS Foundation. When I was junior faculty, I thought it was really important for the pediatric epileptologist to engage with me. I thought that was kind of the foundation for building a strong relationship. I had a clear interest in this area, but until somebody really kind of approached me as like a younger faculty member, I was always a little bit kind of iffy. So I think just having a really strong relationship, locally between adult and pediatric neurology and epilepsy is super, super important. And then I think just to your point with education, really great point. And I think it starts even earlier in fellowship and even residency for us or adult epilepsy folks or adult neurologists. It's, we're just not exposed to it as much as our pediatric neurology folks. And looking back on my education, there was a big hole there. So I think even in epilepsy and our epilepsy fellowship, having fellows programs and AES, I think that's really, really important. But really, really great point. But yeah, I think even earlier, looking at my own experience.
That's a great point too.